Hi, good morning to everyone. I think we are starting with a pediatric talk, and as we see, only few people are here, so I thought we could have a one-to-one chat. I have been asked to talk about multi-organ transplant in children, but I'm a hepatologist, and when it comes to a multi-organ transplant, it's more than two organs, and top of the list is combined liver-kidney transplant. There are other transplants, but I looked into the literature, what happens in India about multi-organ transplants, and apparently with the PubMed search, I can't find any other organ a combined liver kidney or combined liver intestine or heart lung in pediatric population. So I'm going to stick my talk to combined liver kidney transplantation in children. So this is the trend of combined liver kidney transplant in adults and children, and you can see over the decades the pediatric combined liver kidney transplant seems to be the same, while the requirement in adults has gone up, mainly because of this mast cell and disease, the fatty liver disease. The kidney is taking the toll. So the indications for liver transplant in children, the most common cause is primary hyperoxaluria. This is followed by another metabolic disorder called methylmalonic acidemia. And atypical hemolytic uremic syndrome used to be an indication before. Now we have a antibody which can be used to prevent this. So I think transplant for this is not happening anymore. And this is followed by Alagille syndrome and congenital hepatic fibrosis. Coming to this combined liver kidney transplant, it's a rare surgery. Looking at Europe, more than 400 combined liver kidney happens in the adults, but when it comes to children, it's only 10 to 30 per year. And you can see just 1% of total liver transplant in pediatrics is combined liver kidney transplantation. So why do we need to have a combined liver kidney transplant in primary hyperoxaluria? And we know that the enzyme is in the liver, and doing a kidney transplant alone will not solve the problem. The kidney will burn out immediately, and we lose the kidney because of the oxalate load. So we have to stop production of the oxalate. So we need to do a liver transplant as well. Sometimes parents who comes with end-stage kidney disease who's on dialysis come and ask me, okay, my child is fine because it's a non-cirrhotic liver disease. There won't be any jaundice or portal hypertension. And these children are on dialysis. They come and say, oh, my child is on dialysis. Why can't I just maintain them on dialysis for a long time? I think you can do for chronic kidney disease, but with primary hyperoxaluria, that's not going to solve the problem. And these children, within a couple of years' time, they have oxalate deposits in their joints, muscle. They have severe muscle pain, joint pain. And then these families come back again in a couple of years' time in much worse shape, saying that we need to have this transplant. My child is crying all the time because it's not, it is quite a painful disease. Once they go for a kidney shutdown, the oxalate deposits in your eye, your vision goes out, and pain, severe joint pain, muscle pain, and these children suffer a lot. So coming to the types of primary hyperoxaluria, there are 3 types. Type 1 is the commonest, where the enzyme is 100% in your liver. So when you do a transplant, it solves the problem. And within this type 1, we have a variant which is B6 responsive, where once we give mega dose of B6, the enzyme restores, and these children can get away with a kidney transplant alone without a need for liver transplant. So we need to exactly segregate this group so that they can have a kidney transplant alone. And then type 2, the enzyme is present all over your body. So doing a liver transplant will not solve the problem because still the oxalate production is there, but still there are few cases where liver transplant has been done for these patients. The UNOS registry also says that hyperoxaluria is the most common cause for the need for combined liver kidney transplant in children, and then you have a lot of other conditions. So I'm going to talk about our personal experience. I think in the last 13, 14 years, we have done around 700, and I think this data is last year's. Now we have done more than, I think, close to 900 pediatric transplants. We have done nearly 22 liver transplant for primary hyperoxaluria alone, of which 5 are preemptive, which means that they haven't gone to stage 4, stage 5 kidney disease. So we can salvage the kidney by doing the liver transplant alone, and rest are a combined liver kidney transplants. And you can see the preemptive ones are younger children. Most of them are sibling of the patients whom we have seen, whom we have done to come for a combined kidney liver transplant. And we have a simultaneous kidney liver transplant and a sequential one. So what is the difference between simultaneous and a sequential one? I think doing a simultaneous liver kidney, it's immunologically advantageous, as if you're going to get both the liver and kidney, it has a protective effect on kidneys for long term. But many of the live donor programs, both the donors and recipients are going to, both the kidney donors and liver donors are going to be two different people. So this doesn't come to the equation. Plus, there is a chance that we might lose the kidney, because immediately the oxalate from the body mobilizes and it clogs the kidney. And so when we do a simultaneous liver kidney transplant, we might lose the kidney as well. So during our initial periods, we thought sequential would be a better option, because we are not having an immunological advantage and there is a chance that we might lose a kidney. But we faced quite a lot of problem post-operatively with these children. So handling these children when we are doing a sequential liver kidney, it's really, really difficult. So I'm going to talk about what problems we face when we do this transplant. So combined liver kidney is the only curative option if they go for stage 4 or stage 5 chronic liver disease. With up to stage 3, we can do a preemptive liver transplant. Usually, we don't jump and do a transplant when they are in stage 1 or stage 2, because within the families, the disease progression is entirely different. One sibling has a rapid progressive disease, and the other child who is on CKD2 might remain in CKD2 for even 10 years. So usually, we don't offer for CKD1 and CKD2. Probably CKD3A or B, I think that's a time where we need to intervene and do a preemptive liver transplant alone. So post-operative immunosuppression is just like your kidney transplant. And this is the algorithm we follow, the type of transplant, how we do dialysis, in which stage, what sort of transplant is the best option. And I think this can be, this is from one of my textbooks. And these are the reference values. So coming to pre-transplant challenges, I think the most important issue is your cardiac problem. The oxalate deposit in your cardiac muscles, so the ejection fraction goes down, and many children come with ejection fraction of 25%, 20%. So we need to do aggressive dialysis to improve their ejection fraction. Because of this oxalate load, they can have arrhythmias, because they can deposit on the nerve and they can have arrhythmias. So pre-transplant, we need to assess them, stabilize them, and usually the anesthetic team asks the ejection fraction to be more than 35%. Sometimes small children on peritoneal dialysis, which poses a problem as well. So choosing the donor, I think in live donor scenario, it's going to be a parent, and they are going to be heterozygous for the oxalate, for the hyperoxaluria. So we check their serum oxalate and urinary oxalate. Though they are heterozygous, though they don't have a kidney disease or a liver disease, still they can produce high oxalate load. And if they are producing high oxalate load, they are not a suitable candidates to be a donor. One, I think for the recipient, it's not going to be beneficial, as well as the donor who's donating a kidney, who's having a high oxalate excretion, can damage with a single kidney and end up in trouble. So we have to measure both the serum and the urinary oxalate before taking them as donors. So one of the most important post-operative challenge is this. I think more than 60% of these children have bleeding. And whether it's going to be post-operative bleeding, perirectal bleeding, bleeding from ET tubes, bleeding from access sites. And this is mainly because the oxalate causes like an acquired von Willebrand disease. They have a defective platelet adhesion, so they don't clot properly, and also the deposition in small capillaries, so the arteries don't constrict well. So they tend to have higher bleeding tendencies, and usually desmopressin is quite helpful in this situation to control the bleeding. The problematic thing in managing sequential liver kidney transplant, one is hypertension. Most of these children with kidney disease has hypertension on 4 hypertensives. When they are going to be a sequential one, when there is no kidneys, we are not doing a kidney transplant as well, the hypertension is quite difficult to manage, and most of them through seizures, and again, it's quite a difficult issue to handle. And these children can have high infection rate because they can have neutropenia because the bone marrow is involved because of oxalate. So this is our survival. So when we do preemptively, we have 100% survival. When we do simultaneous, our survival is around 71%. But sequential, the survival drops quite dramatically. And this is why we stopped doing sequential and we try to do simultaneous combined liver transplant, because we think we are trying to protect the kidneys by doing a sequential liver transplant. But actually, these children have quite a difficult, stormy post-operative period, and they actually never come out of the post-operative period, so they never have a chance to do a kidney transplant. And that's one of the reasons. This is a data from Europe about combined liver kidney transplant. They have a different outcomes. For the isolated liver transplant, preemptive liver transplant, they have 16% death and 16% progressive disease. And we don't know the reason why, because we have 100% survival. And they had an equal outcome for simultaneous with sequential, with 20% mortality, which is also different from us. So we have might be because of the population, whether because it's a cadaveric donation, I don't know what sort of, how they are choosing the candidates. But this is the real difference what we have seen from abroad and within us. But we don't have much data from other centers in India to look at our results. So I have just 1 minute left. So the other conditions where it requires combined liver kidney is Carelli's disease, where they have polycystic kidneys and liver. Sometimes based on the liver function and kidney function, we can choose either to go for a liver transplant first or a kidney transplant first, because we don't have the necessity of doing a liver first, as in primary hyperoxaluria, and then to go for a kidney. So we can choose whichever organ is not doing well, and they can go for a transplant and do a transplant for the other children. So we have done nearly 3 children with this problem. Methylmalonic acidemia, it's a metabolic disorder where the enzyme is present all over the body. Sometimes they have liver disease, they have kidney failure. Doing a kidney transplant alone even can help these children, as it gives probably around 5% to 7% of enzymes. So rather than a combined liver kidney, if they have a kidney failure, we can try doing a kidney transplant first to see whether it's compensating for their metabolic need. And then if it's decompensating, we'll go for a liver transplant.
Apologies, but we will.
Yeah, I think I'm concluding. I think with this thing, the most common indication for a combined liver kidney is primary hyperoxaluria. When come to live donor scenario, we have to be quite careful in choosing donors. One, it can affect your recipients as well, donor health. And post-operative complication, anticipate it, as you will have problem in it. It's not going to be a smooth ride. And simultaneous liver kidney transplant is the optimal way, even though there is a risk that you can lose the kidney. But managing the patient and bringing out of ICU, that is the best one. And we have to try to increase the deceased donor liver transplant in this scenario to have a good outcome. Thank you.